Welcome all of you joining the public presentation organized by the MFL Occupational Health Center. Today's the topic is protecting workers from COVID-19, the transmission, ventilation, and the law. Today, we are so honored to have three special speakers. They are from the state, Ontario, and Manitoba here. First of all is Dr. Lisa Brosseau. And then the second one is John Oudyk. And last but not least is Dorothy Wigmore. We would like to begin by acknowledging that we are on the Treaty 1 territories, the traditional territories of the Oudyk, Greek, OG Greek, Dakota, and Diné people, and the homeland of the Métis Nation. We respect the treaties that we were made on these territories, and we acknowledge that we all treated people. At the Occupational Health Center, we commit ourselves to a process of reconciliation with Indigenous community. So for the audience participation, the host has muted all the participants. Please keep your microphone muted during the session. To ask the question and the comment, please put it on the chat box section on the right side of the screen. The presenter will try to answer them in order. And then we may not be able to answer all the questions during the session. Will you please connect with us afterwards to follow up? And our session will be recorded and posted on our website and social media soon later. So I would like to introduce you the Manitoba Federation of Labor Occupational Health Center. We are now located on 167 Sherbrooke Street, Winnipeg, Manitoba in Canada. So we are the community health center funded by Winnipeg Regional Health Authorities. We provided the services to the Manitoba workers with work-related health issues and work closely with the joint health and safety committees. So please visit our website for more information and the resources. So now this is the time for us to introduce those three special speakers. First of all, Dr. Lisa Brosseau. Now she's retired and was the professor at the University of Illinois at Chicago, the School of Public Health from 2015 to 2018, where she was director of the Illinois Education and Resource Research Center. She's began her career as an academic researcher and educator at the University of Minnesota School of Public Health, where she directed the industrial hygiene program. Her recent research focuses on respirator fit, using the real-time methods and stimulate workplace tasks to better understand how fit is influenced by realistic head and body motions. Dr. Brosseau has written several articles for the Center for the Infectious Disease Research and Policy, focuses on respiratory protection for healthcare and other workers during the outbreaks and the pandemics. John Oudyk. John Oudyk is worked as an occupational hygienist with the Hamilton site of the Occupational Health Clinics for Ontario Workers, OHCOW, since 1989. He's certified with the Canadian Registration Board for Occupational Hygienists and the American Board of Industrial Hygiene. He's also had done on-site exposure investigation and conduct extensive surveys of healthcare and other workers, and been a member of the research teams investigating infection transmission. And he has done extensive work about stressor, mental injuries, including the stress assets, materials, available food, OHCOW, and the Canadian Center for Occupational Health and Safety. And the last speaker is Dorothy Wigmore. Dorothy Wigmore is the long-time health and safety specialist trained in occupational hygiene, ergonomics and stress and work organization issues. She is the pioneer of body and workplace mapping. She has worked for unions and government university and occupational health center in Canada and United States, England, and Maccabi. Her focus is on presenting and reducing hazards. During this pandemic, she has written the fact sheet for workers in 5 different sectors, written and presented about disinfecting and cleaning, helped with worker surveys and worked with unions and others in Canada and the state to share the information about the transmission of and production from the SARS and coronavirus. Now, this is the time I want to welcome Lisa to do the presentations about the transmission.
Thank you, Tiffany. Thank you very much to the Manitoba Federation of Labor Occupational Health Clinic today. Can you still hear me?
Yes.
Okay, I'm getting an error message from Zoom, which is weird. Okay, I will.
What's going on here?
Mute. Can you hear me?
Yes.
Okay, I don't know what happened. So I got thrown out. Okay, hopefully this will work. There's always something. I'm going to talk a little bit about aerosol transmission, and so let me just dive into it so we can stay on track here. So basically people generate aerosols, and we generate aerosols in a very wide range of sizes, and this is just an illustration from there have been a number of studies of people's exhalations. So the graph on the left shows that we generate a lot of small particles when we breathe. And the graphs on the right show that we generate both a lot of small particles. These are about around the range of 0.1 up to about 10 when we speak or when we cough, and sneezing is also similar. But we also generate a lot of very large particles, and those are often called droplets in speaking, coughing, and sneezing. And those larger ones especially are going to evaporate down to the smaller sizes. And these next 3 slides are going to show what happens in very general terms to an aerosol. This is as in a space that doesn't have a lot of ventilation, is what we call still air, just to illustrate what could happen. As I said, people generate lots of air, lots of particles. They're in a wide range of sizes. And this is showing somebody talking, sneezing, coughing, or whatever, generating this wide range. And the person standing near them will be exposed to that range of sizes. And so some of those larger sizes, or some of those particles, could be propelled straight into your mouth or your nose or your face if you're standing nearby. But you can also inhale particles standing nearby, both large and small. But of course, that person who's a little further away isn't getting an exposure right away. With time, though, what happens is these larger particles will start to deposit and through gravitational settling. The middle-sized particles are going to, and smaller ones are going to be dispersing. And the smaller ones in particular will disperse due to diffusion throughout the space until you get to the point where you have a fairly even distribution throughout the space of those smaller ones. And many of the largest ones have now deposited onto surfaces, and there still may be some moderate-sized ones out there. And what I'm showing here is that you can have inhalation still going on at both the near location, but of course now at the far location. If you add ventilation to this picture, you will get more dispersion more quickly, and you will get removal if the ventilation is working the way it should, such that air will, exchange and clean air will enter the space. So that's why we talk about having air changes per hour. And I'm sure John is going to talk a lot more about that. This is just to illustrate that all of those particles that I just talked about, and I drew a line at 0.1 because that's about the size we're worried about with respect to human-generated aerosols, that anything from 0.1 to 100, and I should say even over 100, can be inhaled and will deposit somewhere in the respiratory system. The larger the particle, the more likely it is that it's going to deposit in the upper regions, like your nose and above your pharynx. The smaller particles are going to make their way deeper into the lungs, and the very smallest ones have a higher probability of making their way all the way to the alveoli, the air exchange regions. So this is to illustrate what you often hear people talk about is the droplet and airborne transmission. And that's a very outmoded way of thinking about exposure to particles. We don't really, in aerosol science and industrial hygiene, think about particles as having this dichotomy. Instead, we recognize they occur in a wide range of sizes. And I added, and I and others have added aerosol transmission to this mix simply to illustrate that you have not just inhalation or droplet propulsion, but that you have inhalation at a close range. Airborne transmission is usually reserved for inhalation of small particles, and those are usually, that's thought to occur at very far distances, usually outside of a room or in a large room far away. And it's thought to be very rare. And that's why people have been pushing back, infection control people and others have pushed back on this, this discussion about aerosols, because they think of inhalation as only occurring at long distances away. But what I hope you will take away from this is that because we generate particles in a wide range of sizes, that there's both inhalation and propulsion of particles, large and small, near the source. So that should explain why we're concerned as occupational hygienists about aerosol transmission in spaces, and why we're concerned about source and pathway and receptor controls. I don't have a lot of time to review this. This was one of the first articles I wrote for CIDRAP, talking about the biological plausibility and aerosol transmission in general. And at that point, back in March, there were limited data, but there were some that were suggestive of the biological plausibility of aerosol transmission. These are the criteria that one would need to satisfy to demonstrate that aerosol transmission is biologically plausible. And Dr. Rachel Jones and I, several years ago, wrote this article that describes these criteria in some detail. And we identified the kinds of evidence that you would look for each of our criteria, and identified them in categories of weak, moderate, or strong. Today, if I were to had the time, I could review all of these and demonstrate that we have established strong evidence in at least two of these areas, that there is aerosol generation, viable aerosols, and viral aerosols from patients, from people who are infected. And this occurs not just from those with symptoms, but those without symptoms. We've got data now to demonstrate that it is viable as an aerosol for some period of time. And there's now viable sampling in patient rooms that illustrates this, that you do have patients generating infectious aerosol. And then finally, we know the receptor, and we know where it is in the respiratory system. The only thing we lack is experimental infection in humans, which of course would not be ethically appropriate at this time, but we certainly have a lot of natural experiments going on all around us, demonstrating human-to-human, person-to-person transmission, much of which can really only be explained by aerosol and inhalation transmission. So Dr. Jones and I suggested you take that weight of evidence and add up all the criteria. The maximum you could get would be 9, so we're pretty close. SARS-CoV-2 is considered a risk group 3 organism, meaning that it has few treatments and no prophylaxis or vaccines at this point. and that it can be there's some significant mortality, at least in some risk groups. So it turns out to be equivalent to tuberculosis and even a little more hazardous than SARS in terms of its weight of evidence with respect to aerosol transmission. When we think about work, and of course that's where I spend most of my time thinking about transmission, the factors that we know at work are the same factors for the community as well: indoors, enclosed spaces, low ventilation, lots of people, long periods of time, and obviously also close contact with people. And I've just shown a few of the places where we've had clusters and outbreaks for COVID-19. Instead of this hierarchy of controls, I've been suggesting that people think about this source pathway receptor model. It helps a little bit, and because each person can be a source, and that's the unusual feature of considering an infectious organism, is that each person, whether they're a worker, a co-worker, or a member of the public that you're interacting with, can be an infectious source. And they're mobile, they move around. So it makes life a little more complicated when you're trying to think about controls. Obviously, source controls, anybody can be a source. So I've just outlined one potential person. That person is talking, so they're generating a lot of particles. And if you think about the pathway, basically it becomes the whole room is the pathway. So we're trying to interrupt a dispersion of these particles throughout the space. And obviously the receptor, the most at-risk receptor, are the people who are closest to that person, but anyone eventually will be a receptor if the concentration builds up long enough and there's a long enough exposure. In the context of source, pathway, and receptor controls, I'll give just a few examples leading into what John is now going to talk about with respect to ventilation, which I think of as a pathway control. Source controls essentially mean what can you do with respect to the source itself, and that's again the infectious people. Well, obviously much of what many of us have been doing is staying home, and so that's removing workers from their workplace and allowing them to work remotely. That obviously is a very effective method of controlling exposure and source. You could screen and test people to identify those who might be infected and infectious. It doesn't always work, however, if those people do not have symptoms and that means fever or cough. Or you could adjust work schedules to limit the number of people or the time that they spend in a space. In terms of pathway controls, some of the things most of these have to do with ventilation. You can increase dilution air, meaning air changes per hour, but you still need to think about the distribution of that air in the space. You can increase the distance between people, but as I mentioned earlier, eventually particles will distribute throughout a space, and so you do have to be careful about the time spent, not just the distance. And I didn't show the data, but coughs and sneezes do easily travel well beyond 6 feet. And then you could consider what I guess we would call local exhaust ventilation, which is the addition of air cleaners and other methods of cleaning and removing the particles from the air. These portable air cleaners have the additional opportunity of adding more mixing or air changes if they're designed properly and work correctly to a space. And finally, just briefly, receptor controls, which of course are at the bottom of the hierarchy. Usually we think of these as personal protective equipment, and the only real personal protective equipment with respect to aerosols would be respirators, not face coverings or surgical masks, which may be source control but are not inhalation protection. And we've been recommending people think about eye coverings, because there is some concern about exposure through transmission through the eyes. And then I've added ventilated enclosures, a couple of examples with taxi drivers and bus drivers, where you basically put the worker in a space where they're entirely separated from anyone who could be infectious. And that's pretty much the end, what I was going to say.
Thank you, Lisa. So now I would like to invite John Oudyk. He will be doing the presentation on the ventilations.
There. Thank you, Tiffany, and thank you, Lisa. It helps when you unmute. So I'll be dealing with the ventilation. And first of all, I want to thank the Manitoba Federation Health Center for inviting me to talk. I'm from the sister clinics in Ontario, where the Occupational Health Clinics for Ontario workers. And although the Manitoba clinics was set up before our OHCOW clinic, there were clinics in Ontario before the Manitoba one. And I just want to brag about that and bring that to people's attention. And another thing to brag about, I'm a grandfather or an OPA, and so I have the prerogative of showing pictures of my grandchildren. And I want to bring that to kind of a case study. My grandson just started JK this September, and 3 weeks into JK, he was isolated in the sick room because of a runny nose, and his mother had to come and pick him up. And she drove in the car with about a half an hour with him and his sister in there. And then she was having a rough time, so we picked him up for the afternoon and had him at our place. And the next day, his mom was sick, and his dad also had a scratchy throat, so he had to stay home from work. So my grandson and daughter came over again, and he showed us all the schoolwork. And one of them was a coloring thing on cough etiquette, how you have to cough into your sleeve. And while he's showing me, he coughs into my face. And so I gently reminded him about the etiquette. He said, "Oh, that's just for school." And I was shocked. Here he's only 3 weeks into JK, and he's already separated what he learns at school from real life. Anyway, I got sick that evening, and a few days later, my partner got sick. My son, who lives in our house, got sick. And a few days later, his girlfriend got sick, and my grandson's sister also had a mild case. My grandson and his dad got tested for COVID, and they were both negative. However, it was a good example of how fast an infectious disease can go around. The symptoms came on fast, 1 to 2 days. Everyone got it. Half of his class was sick. It eventually went through the school and other classes, and half the teachers were off. However, COVID is different. Most cases don't spread to more than 1 or 2 people, but a minority of cases spread to a lot of people. And these are the super spreader events. Sorry for the spelling error there. Super spreading events is an interaction between a person, an environment, and a time trend of the disease. And it's called a Pareto distribution, where 20%, or I've seen even 10% of the cases can cause 80% of the further infections. And people have been focusing on the 3 C's. The 3 C's are crowded places, close contact settings, and confined in the closed spaces. And and at the bottom here, you see what should you do. The middle one there is where possible, open windows and ventilation. So there have been outbreaks like this in Manitoba. I looked on CDC and found one in Brandon meatpacking plant, the Maple Leaf Foods there. And you could add a 4th C, being cold temperatures. The virus seems to survive better in colder temperatures than warmer ones. In Hamilton, where our clinic is located, we have just had one that was on CDC too. It's called a company called Spinco, which has stationary bicycles, and they were doing everything they were supposed to be doing, separating, wearing masks and everything, but 48 primary cases came out of there, and it went to households, to schools, to healthcare facilities, and to gyms, restaurants, and retail. and they're still trying, and they're still counting. But I want to take you back to January, to a now famous or infamous restaurant in Gwangju, where an outbreak occurred. The African Pot restaurant on the second floor of this building you see on the right, probably in competition with McDonald's, as you see their logo at the top there. Anyway, there was a paper released in early April which suggested that the outbreak was due to droplet transmission prompted by air-conditioned ventilation, which is kind of funny to say that big droplets were being blown around by a ventilator, but not little droplets. They said their study had limitations. We didn't conduct an experimental study simulating the airborne transmission route. However, Hugo Lee and his colleagues did go to the restaurant and did all those tests, and they came to the conclusion that short-range aerosol spread, something that Lisa was just talking about, did occur, and that it was crucial to prevent overcrowding and provide good ventilation in buildings in order to avoid this type of situation. And here's a picture of the restaurant and the ventilation systems. You can see 4 of them along the top there, and you can see the patterns of the airflow and how the aerosols distributed around that part of the room, and the people in red were the ones who were infected. I also read very early about a bus where people were infected. The red one there was a person who sat in that chair the whole about 2 hours on the bus, and all the people in orange were infected, and the blue one and the pink one also. However, people who had masks on did not get infected in the bus. This was a paper that was published in China. However, it was retracted with no explanation as to why it was retracted, but it's an interesting case. Then we have the Skagit Valley Chorale outbreak on March 10th. 61 people attended a practice, and 52 of them were infected by a person who had a case. 33 were confirmed, 20 were unconfirmed but probable. And actually 2 days before in the Netherlands, a similar case happened. On March 8th, there was a concert and 130 members attended, and 102 of them eventually became ill. 1 died, and 3 of the partners from the people who sang in the choir also died. Members of the string orchestra and soloists were infected, but very few, if any, of the concert attenders were infected, this one is being investigated right now, and it was at a time when in the Netherlands there were only 400 people, so to add another 100 was quite an increase. Lisa talked a lot about this, but I thought this picture was really graphic. Obviously, you see the ballistic particles going out, but you also see a puff, and that puff is what Lydia Burab, who made this picture, talked about as a plume. And the plume is independent of the room airflow, which means you can't stop it with ventilation until it slows down and becomes part of the general air. And so the only way to stop this is put a mask on this person, and even then some will escape probably, but obviously. And here she mentions that it can travel distances up to 8 meters. And I found this on the line recently, which kind of shows it. It shows the particle trajectory for a 320 micron particle, which is a fairly large particle. Your hair is about 50 to 100 microns in size, in thickness. And if you have the smaller particles, you see a different trajectory. And here for the 20 micron particles, these are getting quite small, and then the 5 micron particles. If you put it all together, it kind of looks like this. But when the smoke disappears, this is what you're left with, particles adhering to the wall, the floor, and the body. And all this confusion and misinformation about the transmission reminds me of the Indian folk story about the blind people who were feeling the elephant, and each one had a different part of it and came to a different conclusion. And they all were right about their little section there, but if you look at the whole picture, they all got it wrong. So air quality standards. The air quality standards in North America are largely two of them. ASHRAE 62.1, which is about ventilation. And the criteria there is to try to keep a substantial majority of the people exposed not to express dissatisfaction, 80% or more. And then there's one for thermal comfort, which has similar standards. Now, when we talk about air conditioning units or HVAC, you need to understand what we're talking about. So here we have a picture. The blue arrow is where the return air comes in, and the green arrow is where the outdoor air comes in. It gets mixed. It goes through this orange filter and then through either a heat exchanger that heats it up, or a cooling coil which cools it down, and then through a fan and out. And then on the right here, you can see how it gets distributed through the ducts into the rooms, and how the return air follows other ducts and goes back. Some gets relieved and some comes in from the outdoors. So one thing you might want to do as health and safety representatives, or people who are responsible for the ventilation in the workplace, is first of all go on the roof and have a look, if it's on the roof, sometimes it's not there, and open it up and look inside. It's amazing what you will find. One of the things I like to do when I do an investigation is just take a camera up there and take pictures of what's inside. This is the air that you're breathing. It has to pass through all this. So thought of, if you want to start a little to-do list, first thing to do is to go look inside your HVAC unit. Take a picture too. Measuring airflow. If you put this AccuBalance or something like it over the diffuser, you can measure how much air is flowing out of it. And there are also other instruments that you can measure airflow. They're not very accessible. So what's often used is carbon dioxide. And carbon dioxide sensors are relatively cheap. You see the one in the upper right-hand corner there, but you got to be mechanically inclined to install and get information out of this that's usable. But you can also buy machines. And this morning I came across this one that gives you carbon dioxide, VOCs, and I can't read the other one. I think it's formaldehyde, all for $40, which blew me away. I was tempted to buy it just for bragging rights, but most of them are a little more expensive. You can buy some for about $150 or more, but if you want a really good one, you're probably looking at $2,500, and that's Canadian dollars, obviously. If you're doing these measurements, don't breathe on the sensor. When you exhale 30,000 parts per million of carbon dioxide. Make sure there are no other sources of carbon dioxide, combustion, dry ice, outdoor air entrainment, etc. Outdoor air, it usually has no less than 400 parts per million of carbon dioxide. If your machine is reading less, then it's probably out of calibration. But with lots of traffic nearby, you can be as high as 700 parts per million. So then you just want to check the difference between the indoor and the outdoor. If you take a grab sample, you need to take it at peak occupancy just before they leave, ideally, or before they open doors and windows. And you do not take a time-weighted average. It's actually good to track the pattern over time. It's a surrogate for outdoor air supply. But there can be complications, especially if you have other sources. So if it doesn't work, you can always measure the airflows directly if you have the equipment and the know-how. Most indoor air quality standards suggest not to exceed 1,000 to 1,200 parts per million. If you're going to use a benchmark, 800 parts per million is probably better. But if you're bringing in 100% outdoor air through your system, your carbon dioxide level should be below 600 parts per million. Also, if you lower the occupancy, it will mean you get a lower carbon dioxide, obviously, because people are the source of carbon dioxide. But that doesn't mean you have more outdoor air supply. You're just diluting by lowering the occupancy or source reduction. Here's an example of some measurements I took. And you can see at 8 o'clock in the morning, we're at around 550 parts per million, and it climbs steadily till lunchtime. It peaks somewhere around 4 o'clock at about 950 parts per million. And then as people leave to go home, you can see a gradual decline. This information is a lot better than just taking an average over the occupied time or the 24 hours, because the decay actually tells you something about the ventilation system, how efficiently it can clear the air. Here's an example of it. Here you see a steady climb. By 10 o'clock, it's over 1,000 parts per million, and by 3 o'clock, it's almost at 1,700, and then all of a sudden it drops suddenly. And when we took a look and see what happened, that was when they opened the outside door. They were getting so fed up with the stuffy air that they let the air in, and you can see it drop. And what we found out is this unit was not supplying any outside air in. So this is the worst one I've ever found, and this was a portable. You could see in the morning we're already starting at 1,000 parts per million. So you're breathing what's left over from yesterday, and quickly goes up to over 3,000. And then you have lunchtime, and people opened it up. And then after lunch, 2 classes came into the portable to watch a movie, and they closed the curtains and everything, and then it went up to almost 5,000 parts per million. Now, people have been measuring carbon dioxide in the background environment for many years. And in Hawaii, there's a spot on a mountain where they take the best measurements. And right now, the level this week is around 411 parts per million. And just to give you a bit of perspective, when I started measuring carbon dioxide for indoor air quality purposes back in the late 70s, we were using 330 as our background level. And if you dig through the ice, you can actually capture trapped carbon dioxide from environments in history, and you can go back and actually chart what it was. And for hundreds of thousands of years before us, it ranged from about 180 parts per million to about 300 parts per million, up and down for many years. But now you can see where we are compared to that. Also, carbon dioxide has an effect on the brain. It's a little not very exact yet, all the science, but there are quite a few experiments that have shown some type of an effect. Now, Lisa talked about air changes per hour. And most HVAC systems are designed to turn over the volume of the room about 5 or 6 times per hour if you leave the fan setting on and not on auto. And that's very important. If you put it on auto, the fan turns off when you don't have to cool or heat the air. Usually only about 10 to 25% of the air is being circulated, although I showed you an example where it was totally occluded. There was 0%. And so if you take the 5 or 6 air turnovers, but only 10 to 25% of that air is outdoor air or fresh air, you actually only get about 0.5 to 1.5 outdoor air changes per hour. And this all assumes you have perfect mixing. The air circulates over the whole volume of the room, leaving no dead air spaces, which we know is not normally the case. If you open windows and doors, you probably get more air changes and possibly more outdoor air supply. If you go to 100% outdoor air supply, you won't be able to manage the temperature and humidity in extreme temperatures when it's very hot and very cold. So on your to-do list, make sure your fan setting is on. Thermal comfort issues here, due to the heating and cooling load that 100% outdoor air may bring on an HVAC system, occupants may experience some thermal discomfort. When the temperature outside is 10 degrees, or that's 50 degrees Fahrenheit for Lisa and her friends from the US, that's when you can take in 100% outdoor air, because that's what your system, when it's cooling, is designed to deliver. In the extreme temperatures outdoors, you'll need to adjust workplace clothing. Have to wear lots of sweaters, maybe even blankets, even thin gloves. I've seen that, and space heaters. Open windows and the use of barriers can also disrupt designed quote unquote airflows. You can use a soap bubble gum to see which way the airflow patterns go. And relative humidity will be very difficult to maintain in the Canadian winter. If you're going to look at that, steam injection humidification systems are probably the best if they're designed and maintained adequately. And I would underline maintain. You need to look after these things, otherwise they won't work very quickly. So to-do lists, prepare for thermal discomfort if you're going to bring in lots of outdoor air. Now you can see how old I am by this 1985 diagram, which has been very well used by many people. And you can see here the relative humidity ranges. And for viruses, the optimum range is somewhere around 40 to 70%. Now, if you're looking at an office, here's one that was taken in March. And you can see that the relative humidity and the carbon dioxide follow each other perfectly in the pattern. And that means that the humidity being supplied in this office is being delivered through exhaled breath, which is the carbon dioxide. And that's not how you want to humidify. And notice that we're hovering around 15 to 17% relative humidity. And I just said we needed 40 to 60%. So you might want to look into humidification if this is an important thing. Now, I found this table in a review of all the recommendations for COVID, for ventilating during COVID. And Dorothy told me that my slides often have too little or too small to read, so I reworked it. For outdoor air, they all agree, the American, the European, the Japanese, and the Chinese, 100% outdoor air if possible. And that's a big if, especially in extreme weather. Hours of operation, 24/7 if possible, is ASHRAE. In Europe, run at low volume 2 hours after and until 2 hours before people occupy the building. In Japan, same as ASHRAE. Temperature and humidity set points. These are quite different, case by case for ASHRAE. Need to adjust the temperature and humidity set points in Europe. In Japan, they actually give a range which is much larger than the ASHRAE range, and a humidity range which is much higher. And in China, increase the supply air temperature and heating, and decrease for cooling. And I think that has to do with 100% outdoor air compensating for that, but I'm not too sure. Demand controlled ventilation. This is where you use carbon dioxide as an indicator for calling for more outdoor air. And ASHRAE says disable it. In the EU, this says use a set point of 400 parts per million, which means it'll be on all the time. And in Japan, lower the set point, but they don't give a number. Filters, this is something a lot of people are talking about in North America. It turns out MERV 13 or better. However, in Europe, filter as usual. In Japan, if you're doing 100% outdoor air, filter as usual. Otherwise, just replace them more often. And in China, maintain filters as usual. So there's quite a difference between North America and the rest of the world there. And for washrooms, there's nothing specific in ASHRAE, although if you're running the ventilation all the time, it's kind of implied that it's running. In Europe, they suggest that you run it all the time. Close the lid while flushing and avoid dry water seals. This is pretty well the same in Japan. And in China, because of their experience with SARS, they're very keen on keeping the plumbing vents clear and not having them blocked, and checking water seals regularly. So if you want another to-do list, your health and safety committee or the people responsible for your HVAC unit should probably look at this list and see what they can do from it. On filters, I thought this quote is worth reading. It's from Jerry Siegel from the U of T, who's done a lot of work on filtering. There's no direct scientific evidence of benefit, but some reduced exposure can reasonably be inferred based on the ability of filters to remove particles that contain SARS-CoV-2 virus. In order for filters to have any impact on infectious disease transmission, the transmission has to occur through the airborne route. Filters have to be properly installed and maintained in appropriate systems to treat recirculated air. And filters have to be appropriately designed for the building in which they are used. More importantly, in most buildings, in most situations, filters may be considered less effective than other known control measures, including social distancing, isolation of known cases, and hand washing. In Ontario, the government actually provided $50 million for school upgrades for school HVAC. They announced this on August 14, not giving them much time to implement it. And if you divide it by the 5,000 schools in Ontario, it comes out to $10,000 per school, which isn't a lot when it comes to HVAC upgrades. In fact, it's just about enough to buy a bunch of air purifiers. And you have to be careful because sometimes these air purifiers are an excuse not to bring in more outdoor air. They're often rated as air equivalent air changes. So there's a thing called the Clean Air Delivery Rate, or CADR, and it's roughly, if you take the dust CADR, it's about 70 CFM per 100 square foot of the room that you're trying to clean. So the other problem is the noise level. Generally, in schools and offices, you're trying to keep the background noise level when no one's there less than 30 to 40 decibels. And these things are much higher. Remember, 3 decibels is a doubling of the noise. So here's an example that I found in the literature of a system which has a CADR of 178 CFM. That's what it's rated for. So an office size of 275 square feet. So they use this in an office of 301 square feet. So you can already see that we have a bit of a problem. And then they tried it in 4 locations. We have position 1 in one corner by the window, another one, the other corner, and then we have it kind of beside a bookshelf in an alcove, and then on a desk, 3 desks in the middle of the office all together. And if we had time and we had more interaction, I could have a vote on where you think the best place is. But when they did the measurements, you can see how many, what the CADR for each one of these is. 116, 100 CFM, 115, and the best place was actually 146. And for the life of me, I can't figure out why this one, position 3, was the best of them. Now, when they aged the filters, you can see That 36 CFM catter is much lower and 45 square feet. You almost need 5 or 6 of these in the room in order to actually do what they're designed to do. And this shows a graph that 20% of the original airflow. So another thing to add to your to-do list, if you're going to get into these units, make sure you do your homework, size them properly, and take very good care of them. Otherwise, they just won't do the job. Here's an article I found online, which showed a classroom, 27 teachers, 27 students, 1 teacher, and 1 scientist who was taking the measurements, and 4 air purifiers. You can see them in the different locations. The carbon dioxide level went from 1,000 at the beginning to 2,700 afterwards. And the noise setting at the top rating was 54 decibels. And this was funded by the manufacturer of these cleaning units. But you can see what you're up against. You've got 4 of them in a room, and they're quite noisy. What about other systems like UV? Properly designed, here again, Jeffrey Siegel, a properly designed and maintained UV system, often in concert with filtration, humidity control, and airflow management, has been shown to reduce infections from other viruses. The details of the system are very important. The design of fixtures, lamp type, lamp placement, airflow amount, and mixing. Simply adding UV to an existing system without consideration of these factors has not been demonstrated to have a benefit. Ionizers, ozone generators, plasma, and other cleaning technologies, none of these technologies have been proven to reduce infection in real buildings, even if they have promise based on tests in laboratory or idealized settings. Some of them actually have substantial concerns about secondary issues, such as ozone production. So here we have the hierarchy of controls, and similar to Lisa, at the source, along the path, and at the worker is included. There's a nice poster that you can get from the Harvard Healthy Buildings group, and here you could add this to your to-do list to post it. While again, not all of these may be agreeable, they're a good checklist to think about, at least anyway. Anyway, thanks for your time and attention, and I will turn it over to Dorothy, but I want to leave you with a thought from Bruce Colburn, an artist, singer in Canada, from a song in the line, "Open up the window, let the bad air out."
Hi, now is welcome Dorothy will be talking about the Manitoba law.
Yes, there we go. Okay, can you hear me now? Great. Sorry, I forgot to unmute myself before I got the screen up. So thanks very much, Tiffany, and folks at the Occupational Health Center. And thanks to Lisa and John for agreeing to be part of this conversation. I wanted to be really sure that folks think about how they could use the information that we've got from Lisa and John. And in particular, how the law could be a tool for health and safety committees and others to, when it comes to dealing with the virus and the pandemic. So I want to look specifically about what the Manitoba law says about biological hazards and ventilation. we've got a rather unique provision in the health and safety law here, and that is that there's a definition of health, comes from the World Health Organization. That's the really broad condition of being sound in mind, body, and spirit. And it every time the word health appears in the Act and the regulations, it has to be interpreted this way, as well as with these goals of occupational health and safety, which come from the International Labor Organization and World Health Organization way back in 1950. But they're actually incorporated into the objects and purposes of the legislation here. And what they basically talk about is that, you know, people have to, people's health has to be protected. You have to prevent folks getting sick. You have to protect workers from factors promoting ill health. And the promotion of workers' rights, the 4 rights have been added in recent years. So every time the word health appears in the regulation, it's really, or the Act, it's really broad, and it has to do with prevention and making sure folks aren't getting sick. So when we look at what the law says, we've got employers have these general duties to look after the safety, health, and welfare of the workers that the employer's dealing with. And there's this phrase here, reasonably practicable. Now, just because I trained in England, I happen to actually know where this comes from. And I made a point of including this in the Seeing the Workplace with New Eyes, the committee guide that I worked on some years ago. And this was this is a term that comes from a case in England. And it means that this is, and by the way, this explanation was okayed by government folks in the day. So it'd be nice if they actually understood what it means. So the idea is that the employer has to say, okay, reasonably practical, is it reasonably practicable to fix something, in this case to deal with the virus? But they can't just say it's going to cost too much. They've got to look at what the costs are in time, money, and effort to prevent or fix things. And it's not this even balancing of costs and hazards. The hazards either have to be fixed or dealt with unless there's a gross disproportion. So a great imbalance between the cost of solutions and doing nothing. And the greater the hazard, and as we've heard, this one's pretty serious, the more it's reasonably practicable to do something about it. So reasonably practicable is really a phrase that gives, as I used to say to supervisors, gives them a good excuse for spending money. The other thing we have to remember is that, of course, we aren't always in buildings that are owned by our employers. And in this province, whether you're looking at fancy buildings like the Manitoba Hydro one down here, but every owner has to make sure that the premises are provided and maintained in a manner that doesn't risk the health of any person. So there actually are specific rules around air quality and ventilation. So if we've got an employer, they have to make sure that the workplace has an appropriate air quality and is adequately ventilated. So if we're going to be adequately ventilated, I would argue, means that people are not going to get sick. And the contaminants and impurities are prevented from accumulating in the air in the workplace, is what it says. And there's a phrase, there's also a little clause here in the regulations about mechanical ventilation that applies both to employers and owners. And they have to make sure that it's designed and installed in accordance with requirements of the building code. And I'm going to come to that at the end because I just have discovered something about that. So it has to provide enough air to replace the air that it exhausts. So you've got to have a reasonable amount of fresh air. It has to be inspected and maintained by a competent person. And so that we're, again, protecting the health of workers and minimizing the growth of biological contaminants and their dissemination through the system. So the virus is a biological contaminant. There also then, they talk about air cleaning systems, and John talked about filters. So in this part of the world, employer owners must ensure that any of these HVAC systems that they actually remove particulate, because that's what the virus is, it's a particle, and gaseous contaminants through an air cleaning system that's designed, installed, and maintained to protect people's health. And this picture here is of a dirty filter on the top, found at a school in New Jersey, where I've been doing some work with people and writing about people's successes. And in this case, the Health and Safety Committee was up on the roof, just like John suggested, looking at the ventilation. John also mentioned bathrooms, and there are requirements again here that employers have to make sure that every toilet facility is adequately ventilated. And if you look carefully in this picture, I don't see any ventilation. It's not uncommon that bathrooms are not well done in terms of ventilation. So in terms of chemical and biological hazards, the employer is supposed to assess all information that they can get their hands on respecting a chemical or biological substance, so that's a virus, and they have to do it in consultation with the committee. That little COVID at the side is something a friend of mine sent me. So not COVID, it's the SARS-CoV-2 virus, sorry. And they have to, so the employer has to figure out what the hazards are of this virus, and they have to reassess things if there's a change in conditions, if somebody gets sick, or if there's new information. And certainly with this pandemic, we are getting new information. So this is not something that's just going to, you do it once and that's it. You've got to keep on top of what's happening. So the other thing to remember is that workplaces with 20 or more folks are supposed to have health and safety programs. And the content includes identifying dangers and what's going to be done to stop that happening, including emergencies. And some people might argue that the pandemic is an emergency. And you have to do things like look at resources, personnel, equipment that can respond to an emergency. The program has to have regular inspections about what's going on. So again, checking on that ventilation system, a procedure for investigating and refusals in particular, I'm thinking of here, and for actually revising stuff if things change. So again, now's the time for, maybe long past time for committees to be talking to employers and saying, what's in our program to actually deal with this? So I just want to remind folks that, of course, we have 4 rights in this province. This comes from material that I worked on for the Occupational Health Center. So we've got a right to know, and we're thinking about the virus. We've got a right to know about the virus. You have to have information and training about various things, including how to avoid spreading it and reporting symptoms, and I would argue what's happening with your ventilation system. And we also have the right to refuse, the right to participate, and there's a right to no discrimination or retaliation. So I just want to skip that for 2 seconds and come back to something else here, if I can do that. Sorry. So I mentioned the Manitoba Building Code, and this refers to stuff that John was talking about. So this is a little pamphlet that's comes out from the city of Winnipeg, but it's talking about what's supposed to happen with ventilation in buildings in Manitoba. And so the rules here are that general ventilation, when it comes to outdoor air, the rates have to be at least what's required by ASHRAE. Now, what John didn't get a chance maybe to tell you is that ASHRAE has said that there's all kinds of extra things that need to be done, and that the regular standards just aren't good enough in this pandemic. And so if people want, I'll put in the chat box the link to the ASHRAE document on that. And the other hygiene groups are basically all on board with the fact that special things have to be done. The other thing that the Manitoba Building Code says that air contaminants have to be removed and shan't be, in terms of, and in doing that, you have to use what they call the Industrial Ventilation Manual from the American Conference of Governmental Industrial Hygienists. So there are things in the building code that actually could be quite useful. So that's my thing. There is, we have, the law offers us some tools. And I would suggest that we, as committees or even as individual workers, we've got a fair bit that we could use it, ways to use it to try and deal with ventilation.
Thank you, Dorothy. So we finished the presentation part. This now leads to the question and answer period. I already cut and paste some people question here. I'm going to put it on the share, then you can see. Where is it now? I lost my screen actually. Oops. So sorry, I think there's some technical issues here on my end here. So I just read it, from the Q&A section here, our first question is, what is the viral load that we need to inhale to become infected? 1 particle, 10, or 100?
So Tiffany,
did you see it on my screen?
I can see it. Can you hear me, Tiffany?
Yes.
This is Lisa.
Yeah.
I'm willing to take a stab at this, and I'll tell you, the answer is we don't really know. But I have looked at some of the data, and I think I've come to the conclusion that SARS-CoV, the first SARS, and the novel H1N1 2009 pandemic influenza probably are the closest, offer the closest most relevant organisms. There's some important differences between both of those organisms in SARS-CoV-2. The infectious dose, I think, is what the question is. The infectious dose for H1N1 appears to be about 1,000 particles, 1,000 virus particles. And the infectious dose for SARS appears to be about 300 virus particles. And so that gives you a range. I personally think that based on the little bit of data that there seemed to be available, and most of that comes from animal studies, and it's not, there's no dose response data yet for SARS-CoV-2, that we are probably closer in infectious dose to SARS than to H1N1, so closer to that 300 number.
So, Tiffany, do you want us to try answering the second question here about face coverings?
Yep.
So
we then encourage workers to wear masks even when practicing the safe distancing within the given office space would appear to be the positive safety measure.
Yeah.
Even John or Lisa, we could take on to answer this.
Well, I could take a stab at it, and I'm sure John and Dorothy might have some comments. I actually did write an article about face coverings, surgical masks, and respirators for the CIDRAP website. I can provide a link to that, where I evaluated the data that were available to us at the time. That was back in March. So there are some problems with data that, we don't have some information, but on the basis of filtration, surgical masks and face coverings have generally very poor ventilation. Some surgical masks are a little better than others, but there's really no way to predict which ones will be good. But neither of those fit your face very well. And so if you recall the data that I just showed you about the size distribution of particles that we generate, face coverings and surgical masks may be able to prevent the emission or serve as source control for larger particles. But what's neglected in many of the studies that people are doing today is the enumeration of particles that are emitted around the sides. And there are a couple of papers that have shown at least the air jets that occur around the sides of face coverings, and surgical masks and face coverings in particular, the ones that are ear loop designs, have a lot of gaps toward around the ears. They have gaps in other places, but around the ears in particular. And when you look at visualization of smoke from mannequins wearing these sorts of face coverings, you actually see a lot of air jets and particles being emitted to the sides and backward behind the head. So I concluded in the CIDRAP article that you might consider face coverings and surgical masks as source control for larger particles, but I was doubtful about their ability to prevent the emission of many small particles, both for two reasons. One, because of all the leakage around the sides, but the second, because their filters are not very good for smaller particles. The one thing we are missing and I don't know if I need to talk a lot about respirators, but obviously respirators are very good inward to prevent inward leakage because we fit test them. And a fit tested respirator fits well against the face and thus should have little leakage. And I would hypothesize that you would have very little emission from respirators. So they could be both source control and personal protective equipment. So the problem that I have with telling workers that your mask protects me and my mask protects you is that that's actually not true in a workplace where you spend a lot of time with someone. You don't really know who's infectious and who's not. And if we're worried about small as well as large particles, which we should be, then your source control with a face covering, a surgical mask, may prevent the emission of some of those smaller particles, but it won't prevent the emission of those, it won't prevent inhalation by any means. And so you really, if you spend a lot of time in a space with someone who's infectious and generating aerosols, even if they're wearing a face covering, you may lower the viral load in the space, and it may take a longer time for the particles to build up. But it is still possible that the exposure could be such that you could get an infectious dose. And as you noticed when I just talked about infectious dose, it's pretty low. 300 virions is not a very high number of particles. So my conclusion was in healthcare, in workplaces, not just healthcare, but workplaces in general, that if we have a lot of close exposure for long time periods to people whose infection status we do not know, we should be offering respirators to workers rather than face coverings.
And in this
John,
case,
go ahead.
Yeah, I was just going to say, in this case, respirator can include an N95 if it's properly fitted. And the Manitoba law very specifically refers to the CSA standard for respirators and all the things that have to be done to have a respirator program and to have it tested and stuff like that. And I just want to reiterate that, you know, one of the issues for me is that people are really confusing face coverings and respirators, and are using the word mask to try and sort of cover everything and it's not clear what they mean. This is in the studies as much as in general conversation. And when we know that in the latest study out of the UK says, I believe it's 75 or 80% of people who are infectious don't have symptoms. And when we know that we're putting people in rooms to work on a regular basis. We really need to do what they're not doing in Manitoba, which is talk about ventilation. And that's why, you know, it's so easy to go for these face coverings because they're visible, but we don't see the ventilation. And that's the thing that we've got to make more visible, particularly in this province where they don't, you know, the public health officer doesn't believe that aerosols matter. And certainly not willing to concede on that. The documents that the government provides, I found one mention of ventilation. It was a tiny little thing. It might be a nice idea kind of thing, with all kinds of emphasis on these face coverings. And frankly, I think that this is just, you know, they're encouraging things that are effectively are against the law, in the sense that employers are not providing proper protection for workers. So that's, for me, why this ventilation stuff is really important.
Yeah, if I can jump in too. I've taken a bit of a different approach, looking at the community risk level and putting that into perspective. For instance, in Ontario, we have one region called Temiskaming, where they haven't had a case for weeks, and the number of cases has been very low. It's a very remote area. To me, if you're wearing a mask in Temiskaming, you're doing it because you were making a statement. You're in solidarity. We're all in this together, and this is just something I can do, symbolic. You know, it doesn't mean much, but as far as protection or source control, but it's symbolic. Now, when you've got a little bit of community transmission, then it becomes kind of etiquette. And I think in Eastern cultures, it's more common that, you know, I'm trying to keep my emissions to myself. And as Lisa said, there are some coverings that are better than others and more efficient, and you'd be wise to learn about that. In fact, I heard of one that actually takes the particles and blows them through the covering and creates a whole lot of more smaller particles by taking the big ones and breaking them down. So there are some that can actually make things worse. My daughter lives in Montreal, and they're having a very bad time of things. There's a lot of community transmission, and they cannot, it's a crowded city, you cannot keep distance, and people aren't wearing masks properly. So I advise her to wear an N95 because she needs protection because it's probably out there. So it depends on the level of community risk, in my opinion.
Well, yeah, and here, John, the case positivity level is close to 5%. So it's out there.
Yeah, in Ontario, we've created a website where we've taken the numbers from public health and given them 5 different colors. And that way people in workplaces, they can check what level they're in. And then we have a graded level of protections based on your community risk. So if you're in blue, you do the blue suggestions. If you're in yellow, you do the yellow suggestions. And plus,
could you put that in the chat box,
yeah,
John?
the problem is it's Ontario.
Yeah, but it's very useful in terms of the kinds of things to think about. We've got our own sort of scale here in terms of colors, but there are some parallels. And then Lisa, there was a question there about N95s and K95s.
Let me see, just a second. I was answering something in the chat. So N95 and K95 masks, do you think they're useful? So I'm not sure I entirely understand the question. So an N95, everybody uses that term, but N95 is actually just the description of the filter designation. The respirator itself is usually, it's a filtering facepiece respirator. So it consists entirely of filter material. If you are asking if I think they're useful, yes, I do. If you're fit tested, you know, they should do a very good job. The filters themselves are very good and will be entirely appropriate for the particle sizes that we're concerned about. It's the fit that really matters in the context of respirators. And you'll get if you fit test them according to the way the United States OSHA requires, you should have a fit factor of at least 100, which means the outside concentration is 100 times greater than the inside, or you get 1% penetration through the face piece, not the filter. That should be certainly very adequate in most settings. Where we recommend higher levels of respiratory protection are in healthcare, where you're dealing either with symptomatic patients, and that would be my opinion, or aerosol generating procedures where you're generating higher concentrations. Again, CDC does not require higher levels of protection for higher concentrations, but I do think that that's appropriate. The KN95s are tested in a very similar way in China to the way NIOSH in the United States tests respirator filters. And thus the filter should be just fine if it's, you know, properly tested according to those requirements. Where the problem enters with respect to some KN95 respirators is that many of them are constructed with ear loops, and there are fewer regulations with respect to fitting. And ear loops, you will notice that no respirator manufactured in the United States has an ear loop. They are almost impossible to fit. There's no way to adjust the fit of the face piece against the face if all you have is an ear loop. And so that is where we've run into problems. And anecdotally, people have said to me, it is very hard to fit test the KN95 masks, especially if they have ear loops. But if you can fit test them and do obtain that level of fit factor I just described, then they should be just fine. Because I think that they've been tested with the same type of certification tests as NIOSH uses.
And if I can jump in and add, there have been a number of articles about the ergonomics of the fit of the KN95s, and you know, it's not just North Americans complaining about other people's masks, it's also Chinese people complaining about those masks, that they're uncomfortable, they have a higher resistance often, so they're not as nice to wear if you're wearing them, but if you're in a situation where there's a shortage, yes, they are something to think about as an alternative.
Mm-hmm.
You might also want to think about things like elastomeric respirators in that case.
And elastomeric respirators are the regular respirators with the cartridges that healthcare workers have been using in various parts of the States for some time, but apparently, if I've got the story straight, the Canadian government has finally decided that maybe healthcare workers in this country could be using them too. Out of curiosity, as a question for the crowd, I'm wondering if anybody here has a guess at how many healthcare workers have been infected in Canada during this pandemic as of the end of July. And if you want to write an answer in the chat box. I don't see anybody doing that. So 250, that'd be nice.
I think
Dawn?
it's a few more than that.
It's more than 21,000. Yes,
Yeah.
More than 21,000. And that's because what we have talked about today, both in terms of transmission and ventilation, has not been taken seriously. The lessons from the SARS epidemic have not been learned. A guy called Mario Posami has done a report for the Canadian Federation of Nurses Unions, laying out some of the problems, how many workers, and particularly healthcare workers in this country, have been infected. And it's not just protective gear, the lack of N95s, but it's also the other kinds of measures that were taken in places like China. John, John's done a lot of work around this. What's the difference between China and Canada in terms of infection rate? Is it 6 times higher here?
Yeah, yes, if you look at the percentage of COVID positive people in China, the total is about 4% of COVID positive people are healthcare workers. In Canada, it's close to 20%.
Yeah. So, and the international percentage is about 10. Quebec is about 30, and I don't know what Manitoba is going to be, given all the healthcare workers that have been getting ill and getting infected in the long-term care facilities here recently. But my main point is that you know, that's what we know about in terms of healthcare workers. Who knows about other workers and who's getting infected? And if we don't pay attention to how this virus is really transmitted through the air, if we then don't pay attention to ventilation, it's not surprising that we're getting the spread, and particularly that workers who are in places where they have to deal with people a lot are getting sick. I see somebody saying we're not allowed. Yes, yeah, the healthcare workers are entirely due to community transmission, but it's just not, yeah, it's not true, says Lisa. And so not having proper respirators and ventilation when you're in long-term care or healthcare facilities or places where people are likely, like schools, are likely to be have infections. It's just crazy. We're happy to, I see something about sharing slides. I'm certainly happy to share mine. John and Lisa,
yeah,
you can do that. And there is a recording here that Tiffany has done.
I'm okay with sharing a PDF of my slides.
Yes.
That's not a problem.
Okay.
I just put into the chat a map of Canada that shows the number of healthcare workers that are have been infected across the country as of mid-July.
Yeah, and so in Manitoba, those numbers are going to be a fair bit higher for here. The percentage here was closer to 10%, but they're going to be higher once they start looking into September and October. Yes, somebody says they're not given access to N95s unless you're working with COVID patients.
That's interesting because recently I attended a hearing, and one of the infection control experts actually said the people who are dealing with suspected cases need N95s more than people who are dealing with known cases. And their logic was that you never know when you're going to perhaps have a super spreader in those environments. So it was a bit of a twist on the normal.
Yeah. And the thing is that if there aren't N95s around, these regular respirators are perfectly fine and work well and protect people. And there have been reports done in the States, and there are places in the States that have used them for a long time in healthcare and infectious disease hospitals and things like that. Unfortunately, folks in this part of the world don't seem to know a whole lot about using them or think of them as an option.
So on behalf of the Occupational Health Center, now this is the time to kind of wrap up the session. We really appreciate, you know, Lisa, John, and Dorothy has been given out lots of information, you know, and it's great presentation to share with the audience here. So I really thank you. You're willing to share your slide too. So the session has been recorded. So the slide, I will be able to send it to the participant. Once the recorded session is available, I will send you the link to all of you, and even will be posted on our website as well. So thank you so much for all the audience joining with us for 1.5 hours, to listen and participate and making comments, on the session here. So hope everyone, you work safe and stay well and take good care of yourself during the pandemic. See you
Thank you,
next time.
Tiffany.
Thank
Thank
you.
you. Bye.
I know.
Thanks a lot, folks.